Hello, welcome back to our second lecture on therapeutic misconception. In this talk, we will discuss the contributing factors that generates the therapeutic misconception, the ethical issues that comes from the existence of the therapeutic misconception, and we will end by discussing recommendations that overcome the therapeutic misconception. Well, the major cause of a therapeutic misconception in the research study is essentially comes from the fact that research occurs mainly in the clinical setting, and that clinical setting promotes a therapeutic orientation to clinical trials. Randomized clinical trials are conducted in the clinical settings, not only in the academic institution, but increasingly randomized clinical trials are being conducted by community physicians recruiting their own patients. Investigators and members of the research team wear white coats, and in consent documents, investigators are described as physicians, interventions are described as treatment, and research subjects are described as patients. All of these factors conspire to promote the therapeutic orientation to clinical trials. In regards to misleading consent forms, there was one study that analyzed 321 consent forms in gene transfer research, and their study revealed that research and treatment are commonly used as interchangeable terms. Also, surrogate endpoints such as tumor shrinkage, immune response were discussed, but were not distinguished from clinical endpoints such as survival time and improved quality of life. In another study of consent forms, that study revealed mixed messages in the consent form documents. For example, you may or may not benefit, and also there's no guarantee that you will benefit for studies called Alive, Best, Cure, Enhance, Rescue, Triumph. All these eponyms conspire to promote the therapeutic orientation to clinical trials. There is also a problem with recruitment materials. In recruitment advertisements, it is frequently claimed that the randomized clinical trial offers patients optimal or state-of-the-art medical care. Evidence of the therapeutic misconception via recruitment materials is shown in this example of the NIH website in 2011. Here is a statement from the website. People participate in clinical trials for a variety of reasons. Healthy volunteers say they participate to help others and to contribute to moving science forward. Participants with an illness or disease also participate to help others, but also to possibly receive the newest treatment and to have additional care and attention from the clinical trial staff. Clinical trials offer hope for many people and an opportunity to help researchers find better treatments for others in the future. Focus on the use of the word treatment in this paragraph from the website. Next, I'd like to discuss the role of Equipoise that has been used to justify the ethics of randomized clinical trials. The randomized control trial emerged in the mid-20th century and has become the gold standard for evaluating treatments. However, there has been an RCT dilemma. How can randomization of patients be justified within the therapeutic ethic of medicine? Essentially, physicians in the 50s and 60s were saying, how could I randomize my patient to the best possible medical care in a clinical trial? Well, clinical equipoise emerged as an attempt to answer or to deal with the RCT dilemma. In RCT, essentially clinical equipoise entails that an RCT is ethical only if the medical community is genuinely uncertain which of two treatment arms is superior, and that's why we're doing the clinical trial. As articulated by Miller and Brody in their 2003 article, clinical equipoise preserves the basic duty of therapeutic beneficence within clinical research. They claim that clinical equipoise entails that no subject will be randomized to a treatment known to be inferior. Therefore, according to Miller and Brody, clinical equipoise exemplifies and logically implies what they call the similarity position, which entails that the ethics of research should be based on the ethics of therapeutic medicine. And indeed, that's what clinical equipoise does. It conflates therapeutic medicine with clinical research and essentially rejects a difference position between the two activities. So how prevalent is the therapeutic misconception? Well, in a nutshell, empirical studies of clinical trials, predominantly early-stage cancer trials, indicate that subjects are often motivated to participate in research by the expectation of direct medical benefit, and when asked, they blur the distinction between research and treatment. Dresser, in her article, says it's ubiquitous. Applebaum and Litz says it's an extremely prevalent phenomenon. Some concrete statistics reveal in one study that 30% hold inaccurate beliefs about individualized treatment, and 50% hold unreasonable beliefs about the trial benefits. In a subject interview study involving 1,900 subjects interviewed at 19 academic medical centers, 67% responded that they had joined the trial to get better treatment. I'd like to show a study we did exploring the existence of a therapeutic misconception among Egyptians in a qualitative pilot study that was done several years ago. Our objective was to assess the presence of a therapeutic misconception among Egyptians being interviewed regarding their perspective towards research. It involved 15 Egyptians recruited from the outpatient clinics, and we used a semi-structured interview to explore perspectives of individuals regarding clinical research. Interviews lasted up to 60 minutes, and we analyzed for the presence what we called, or what have other people called, therapeutic misconception 1 and 2. This is shown in this next slide. Essentially, TM1 expresses an incorrect belief that patients' individualized needs, or what will benefit them the most, will determine assignments to groups. Essentially, there's a belief that the intervention will be chosen based on what the physician believes will be best, rather than on a random process. TM2 expresses an unreasonable assessment of the nature or likelihood of medical benefit from participation in research. There's a belief that the physician would not suggest enrollment unless it was very likely to be of help, or that the risk of research must be low. So essentially, TM1 refers to an incorrect belief about how the activity will address their individualized needs, and TM2 regards the assessment of medical benefit that one will obtain from the research, or an assessment of the risk of research that exists in the research activity. And the next two slides shows examples of a therapeutic misconception labeled TM1, and this slide shows the narrative of the interviewer and the narrative of the participant. So the interviewer, in response to the question, how would you feel if your doctor would not know which drug you would be taking? Response from the participant, there's no way that my doctor doesn't know what I'm taking. The next question, would this study be acceptable for you? If the doctor says it's better, then I'll try it. If he tells me it's not good, then I won't try it. Another response, the interviewer would ask, would you agree to participate in this study? I think my physician would know better. I'll take what they suggest. They'll probably try the new drug to see how it helps me. And then finally, if a research study involves comparing a new drug with a current one, I prefer to pick the one with the fewest side effects. All these statement reflects how participants feel that by joining research, the intervention will address their individualized needs. Examples of TM2 regarding a misestimation of the benefits and the risks. In response to the question, would you agree to be in a research study? Response, I definitely would agree to participate, but the new drug must have a better impact than the old drug. In response, another response, certainly, these studies won't have side effects. The goal is to improve health and not cause harm. Another response, it must have some guidelines that guarantee that it will protect me. I must be at least 90% reassured that it's something safe. I'll take it if my doctor tells me that it's better. All these are examples of the therapeutic. So why is the presence of therapeutic misconception important? Well, essentially, its presence presents challenges in obtaining valid informed consent because participants, as we shown in the previous study, fail to appreciate adequately the risk-benefit ratio. And this failure to appreciate the risk-benefit ratio invalidates informed consent. The blurring of the distinction between research and therapy risks undermining the entire process of informed consent. So how could we overcome the therapeutic orientation to clinical trials? Well, one, we need to raise consciousness about the ethical significant differences between clinical trials and medical care among our research staff and among the participants whom we recruit to participate in our research studies. And we also have to pay careful attention to the language describing clinical trials. We have to pay attention to the language in recruitment advertisements, and consent documents should avoid contributing to the therapeutic misconception. This slide gives examples of what to say about benefit in research consent forms. You may or may not benefit. Personal benefit cannot be guaranteed. This trial is not intended to benefit you, although we will monitor results for any improvements in your condition. You are unlikely to receive any lasting benefit from joining this study. Participating in this trial will not improve your health. In terms of the process, a recommendation is that when the investigator has a prior treating relationship with the prospective subject, someone other than the investigator should obtain informed consent trials. So in conclusion, the ethical conduct of clinical research requires clarity about how clinical trials differ from medical care, and we must take proactive steps to avoid the therapeutic misconception. Thank you very much.